Hello, my name is Rafiqul Islam Maruf. I'm from Kyushu University Hospital, Japan. I also work with Grameen Communications, Bangladesh. Today, my presentation topic is standardization of personal health record in the portable health clinic system. This is a joint research initiative between Grameen Communications and Kyushu University. Before I focus on the standardization of personal health record, please allow me to introduce portable health clinic system first. Portable health clinic is a telemedicine system with a special focus on non-communicable disease. We initiated this program in Bangladesh in early 2010. Now the first question arises, why we started this program in Bangladesh? To understand this, I think it would be better to look to the country's health profile. Bangladesh is a small Asian developing country. We have about 160 million people. 30% of our population live in the urban area, where 70%, the majority, live in the rural area. The people, those who live in the urban area, they have a good number of hospitals, clinic with quality doctors. But the village where the majority of people live, they are suffering from the lack of healthcare facilities. There is insufficient hospital and clinic and lack of qualified doctors. In this situation, we thought how we can provide a better healthcare service for this huge community. Then we come up with the idea of telemedicine. We thought the telemedicine with the support of urban doctors could be a solution for them. Because majority of our doctors stay in the urban area. So if we can connect it with them, at least village people can get in touch with the doctors and get some service. But now it comes the second question. Do you have enough doctor in the urban area? If we look to the graph of 2015, it shows, according to WHO, we need at least 12 doctors for every 10,000 population. But in case of Bangladesh, we have just 5 doctors. If we compare with Japan, Japan has about 24 doctors. So what does it mean? It means the patient seen by 24 doctors in Japan should be seen by 5 doctors in Bangladesh. In other words, the patient seen by 5 doctors in Japan should be seen by 1 doctor in Bangladesh. So we can understand this is a very critical situation, because doctor-patient ratio is very important to ensure a quality service. So in this current situation, it's very difficult. And if you look to the situation of the nurses and health workers, the situation is more worse. So we need to do something to improve the doctor-patient ratio to ensure the quality service. So what could be the solution? So when we look for the solution, we find the simple solution is to increase the number of doctors. But this is not the easy solution. We cannot increase the number of doctors all in a sudden. It takes time, it takes money. But the good thing is that Bangladesh government is trying to increase the number of doctors by increasing the number of medical schools and hospitals. However, we find that it will take another 20 to 25 years to reach to the level of 12 doctors if our current trend continues. So we cannot wait for that time. We need to do something in parallel. So what could be the alternative? When you think about the alternative, we find that to improve the doctor-patient ratio, when we cannot increase the number of doctors, why not we try to reduce the number of patients? But the question is, how we will reduce the number of patients? Then we come up with the idea of introducing preventive healthcare. Reduce the number of patients by introducing preventive healthcare so that people can understand their health problem in early stage and prevent them from being severe. So now we have two keywords. One is telemedicine and another is preventive healthcare. So combining these two, we have come up with the idea, what we call portable health clinic. So what is portable health clinic? Basically, portable health clinic has four major components. The first component is a box, medical toolbox that contains medical sensor. It has a different sensor so that we can measure about 15 vital information. We also have the second component with this system is village health worker, because we don't have doctor in the village, but we can produce village health worker. And third component is online server system so that we can transfer data from village to urban doctor, from patient through the online system with the doctors. And fourth component is call center, doctor call center. So these four components together is the portable health clinic system. And this is a workflow how PHC or portable health clinic system works. So basically, we take the vital information with the support of the health worker from the village, and we share this data with the urban doctors. Whenever needed, the doctor provides the teleconsultancy to the village patient. To understand this better, I have a short video presentation. Please have a look, and I hope this can help you to understand it better. As I said, that this is basically first component was a toolbox with medical sensor. So first we need to register a patient, and all patients are provided with a unique barcode ID to identify each patient separately. Then using the medical tool, the vital information is collected, and then this data is inserted in our PHC application. The application has a triage protocol that classifies patient in four categories: green, yellow, orange, and red. Orange and red patients are severe and they need doctor consultancy. So they are connected with the city doctors and they get the online consultancy and provided with a prescription. The prescription is provided in the village because the printer is with the box. So the patient being at village, they can get the consultancy from the city doctor and get the prescription instantly through the support of the health worker. This box has several medical sensors. As I mentioned, we can collect, actually we can collect about 20 vital informations. Here a list. And now let's come to the standardization of PHR part. These days, a personal health record is not only a collection of personal health data, but also a personal healthcare and disease management tool for individual patients. And it's considered as an indispensable tool for patient engagement, especially in the area of non-communicable disease like hypertension and diabetes. What is actually the 70% causes of death in Bangladesh. And that is why we had a special focus on NCD in the PHC system. And a standard PHR system is expected to manage information regarding an individual's vital sign, physical exercise, behavior, and location using built-in sensor based on the Internet of Things technology. And PHC toolbox is a sort of IoT. And patients will have access to monitor their personal health or medical data. And patient can express personal opinion reflecting the progress of their treatment. Actually, this helps the physician to confidently change the policy and intervene when necessary. This patient-reported outcome, or PRO, is also considered very important because the PHR system can function in coordination with PRO for better generation of data with accuracy. Thus, this PHR is getting very important. Unfortunately, in most of the general hospitals clinic in Bangladesh, they don't maintain the electronic medical record, EMR. Every time patient come to the hospital, they need to go through the same process of checkup and see the doctor. So the PHR is not considered at all. And there is no standard for PHR in Bangladesh as well as in many developing countries. However, when we started PAC in early 2010, from the very beginning, we considered PHR and EMR in our system. But as we have initiated in our own model, we have generated a PHR monitoring interface for the patient. The patient can access to their data and they can see the progress of their health status. Actually, this helps the patient to be aware of their health condition, and they feel serious. They feel to go to the doctor whenever there is a change. Now we feel it's time to standardize our PHR because we developed with our own requirements. But now, as there are some standards around the world, we feel that it's time to standardize the PHR system so that the patient can use these information anytime, any place. For standardization of the PHR PAC, this study considered PHR framework recommended by 6 Japanese clinical societies as the reference standard. They proposed 41 general clinical data items with specific units and expression as self-management item sets. And they also proposed core data item sets corresponding to each SMIS that contains the minimum data items necessary for each disease. So basically, they focused on 4 problems, including diabetic and hypertension. This study adjusts all missing items in the PHR of the PAC compared to the standard proposed by the Japanese societies. So besides this missing item inclusion, we also have some additional component in the system based on the local requirements. And beside the basic PAC system, we also had MCH and iCare module. So based on that, we also need added some new parameters in the system. And this graph shows the Japanese PHR recommendation. You can see that there are 41 parameters, and they also has 4 CIS for 4 specific disease. And the color part indicates the mandatory or very core component that is required for each disease. Now, when we compare our PHR and PAC, then we can see, if we consider the hypertension and diabetic part, that majority of the items are already in the system that are marked with the round mark. But triangular mark indicates that we also have this component in our system, but in a different form. From the medical history recorded in our system, we can collect a part from there. And we also have a module we call telepathology that is also included in the PAC system. So from that part, we can collect another part. So altogether, we have about more than 8, a good number, except 4 components are missing. So now we are working how we can include this 4 component, and we are as portable health clinic is a based on the medical sensor. So we're looking for this kind of sensor. If we can find, we can accommodate them in the system, and it will be a standard based on the Japanese system. And this is the telemedicine system we have included in the system. So in conclusion, I would say that we can standardize the NCD module of PHC, but for tele eye care and tele MCH care, we need to work further to add new parameters and for standardize it with compared with the other standard. And also, we know that HS7 is getting very popular, HM7 International of FHIR, Fast Health Interoperable Resources. This standard is getting very popular all over the world. So we are moving to FHIR from our current standard. So in our next level, we will work for the standardization of our system based on FHIR. And this concludes my presentation. Thank you very much for your patience.